in cases of thin, soft tissue types, should implant be placed at crestal level or subcrystal level?
The question is, at what vertical position do we place the implant? And we approach this a little bit different in the anterior aesthetic region and in the posterior anesthetic region. In the anterior region, we use the different reference points, like for example the cement-enamel junctions of adjacent teeth, or the mucosal level at adjacent teeth, or for example the prospective margin of our crown, which we can plan with by using a surgical template. And if we use, let's say, bone level implant, then it's recommended to have at least 3 millimeters of distance to get the emergence profile. For aesthetic reasons, so again to generate the correct height of the crown. In the posterior region, in which the pink aesthetic is not so important, the traditional recommendation from the industry for bone level implants was to place a bone level implant epicrestally. However, as this participant correctly made a question, so in situations with thin mucosa, for example, a mucosa thickness of 1.5 millimeters, this is quite an extreme case. In that case, we know that after the placement of the implant in the transmucosal position, so which means either after implant placement or either after a bottom connection, the cases with thin mucosa, they suffer more bone loss. So basically what happens that basically it's like a physiologic reaction, and the amount of post-surgical bone resorption is higher in situations with thin mucosa, but pretty much all the cases end up with 3 to 4 millimeters of biologic width. So to answer the question, yes, in cases with thin mucosa, you should place the implant deeper. How deep do you place it? So you place the implant, you would like to have at least 3 millimeters from the implant shoulder up to the superficial surface of the mucosa.
Okay. And next question would be, do perforations of the cortical bone help to provide blood supply for a GPR augmentation?
Yes, absolutely. So the atrophic bone defects, which are, of course, they're covered with corticalis, they offer really minimal amount of biological potential for the regeneration. And we know in particular from preclinical studies in different small and large animal models that by perforating or by doing a decortication of the surface of the corticalis, we can accelerate the healing, so basically the osseointegration of the bone substitute, and we can also increase the amount of new bone within the augmented region.
Does the incision technique change if there are neighboring implants instead of teeth?
Mm-hmm. Yes, absolutely yes. So in case of adjacent implants, we always use a papilla preservation technique, and we always use a paramarginal technique. So if you have a tooth, you might decide to cut the papilla. You might decide to place your incision in the sulcus. But with an implant, we never do this because we want to avoid any type of bone loss on an implant.
If you do not have access to a CBCT or no access to scanning, no access to a scanning, what would you do to make sure you can do a procedure as best as possible?
This is of course the availability of the cone beam CT or the three-dimensional imaging is not really so it's not present really in all the parts of the world. Anyway, I think for few decades, many experienced clinicians were able to perform really very nice surgeries and very predictable surgeries even without cone beam CT, so this can be done. But anyway, today I think it's really important to try and compensate the missing information, and we can do this by carefully performing a palpation or the bone mapping. So you can use a periodontal probe or an endodontic needle, so you can try to do some kind of per mapping of the bone. So this can be even done by sectioning the models. So you can use regular impressions and then section these, for example, so they section the model exactly in the middle of the gap in which you plan to place the implant. And then it's pretty much, so by adding this information of the thickness of the soft tissue, it's possible pretty much to map the three-dimensional, the size and the three-dimensional of the bone ridge.
Now we also have an interesting general question. How many implants would you ideally place for a fixed restoration in edentulous cases?
I think there is no ideal number, but I think that so the number is what is let's say predictable, what is evidence-based. And I would say for a dentulous case, if you choose a fixed reconstruction on implants, then we need at least, or it's recommendable to use at least 4 implants up to 8 implants. I would say that less than 4 implants is still missing the solid amount of evidence, and more than 8 implants might be considered an over-treatment. For 4 implants, of course, we're going to use the procedure. So basically, it's going to be like one cross arch reconstruction. So basically, one segment on 4 implants. So again, this is biologically, this is sufficient. So the amount of osseointegration is sufficient. But from the prosthetic point of view, it is advantageous to be able to have more segments. Let's say, for example, 6 implants, which give the possibility to do 2 or 3 segments, or for example, 8 implants, we can do 8 segments. And the biggest advantage of segmentation is that from the prosthetic nature, that in case of prosthetic complications, which still we have to be honest, and still the chippings, in particular the chippings of the metal ceramic and also the full ceramic, this is quite an often frequent problem. And of course, by having this type of reconstruction, a small segment, it's much easier to manage the repair of the fractured ceramic.
A question about cantilevers. How predictable are implant crowns with cantilever? What do you prefer, 2 implants or 1 implant with a cantilever?
Mm-hmm. So of course, the important question is how many implants are we reconstructing? So if we have 2 or more implants, then I would say cantilever there is no problem at all. So there are no problems. We know from the literature that there are a minimally increased amount of technical complications, in particular the screw loosening. But the interesting question is, what about a situation with single implants, in which we could, well, let's say 2 missing teeth, which we can restore either with 2 implants, with 2 crowns, or with 1 crown with a cantilever. And the problem is there is not a lot of evidence. There's not a lot of data with this particular reconstruction type. However, we know that from the osseointegration point of view, there shouldn't be any problems. So this is what we consider in our daily practice. When the patient asks this, we explain them that there is no problem for the implant. So the implant survival is not compromised. However, we expect the rate of technical complications to be increased. Of course, the following question is, are we reconstructing in the posterior jaw segment or in the anterior? And I would say that in the anterior segment, in which the chewing forces are not so high, there are not too many problems. So in the anterior, my first choice is for 2 missing teeth is to place 1 implant and a cantilever. So this is typically done for missing lateral incisor. And in the posterior segment, I'm open for both questions, but for prosthetic reasons, so to reduce the amount of possible technical complication, I prefer to place 2 implants and to restore them with 2 crowns.
A question to the loading protocol. In which cases progressive loading is recommended or beneficial?
I think in no situation at all. So progressive, this would mean really to gradually increase the amount of the force on the tube. So either we have an implant which is not reconstructed, we can restore the implant, keep it not in occlusion. But I would say from the moment that in which we restore the implant, I think the situation should be that the implant should be able to withstand the occlusal forces. So for me, again, the question is not whether or not to use the progressive loading, but whether or not to use immediate restoration.
When inserting a single implant in the aesthetic zone, which is the ideal temporary prosthesis?
So the ideally provisional. So the question is now, of course, do we choose an immediate restoration? Of course, if we go for immediate restoration, in that case, we're going to use a resin crown, so which can be bonded either on a metal or on a resin abutment. But in cases in which we, so the typical case in the aesthetic situation in which we choose to go for submucosal healing and so on, so it takes more time for the healing. In that case, we need some kind of maybe not implant-supported reconstruction. So there are two possibilities, two removal possibilities. I would say for clinicians, for us, it's much more efficient and predictable to use removable appliances. So either we use a classical, let's call it the remover partial prosthesis with wire clasp. So this is a typical reconstruction which we use. Or the other options is to use a thermoplastic splint, which can be added with some resin for the missing tooth. So this is something also very predictable. Personally, I don't really like the aesthetics of this situation and also the hygiene. Or in some cases, in patients really desiring something fixed, we can use a provisional resin bonded adhesive bridge, so a Maryland bridge, which is bonded on both sides of the gap.
So I'll continue because we have a lot of incoming questions. What do you do when you perforate the sinus membrane, and how long do you wait for the next operation?
So if you're doing a lateral window and you perforate the membrane, in that case, the first thing you want to do is you extend your window and you try to continue. So basically by mobilizing the soft tissue as far away as possible from your perforation. And also very often the perforation is it's like a line. So basically you get it tears. So what you do, you really try to start mobilizing in that direction, that you really reduce the amount of risk of making this rupture larger. If you're doing a Summers technique, so the transcrestal technique, then there is not a lot of chance. Then you have to stop your procedure and you have to close the flap. And in that case, I don't think that there is any evidence. But my recommendation would be to wait at least 3 to 4 months.
Okay. So what is the minimum height of bone in the maxillary posterior region you feel comfortable to place an implant and doing sinus lift together?
So this really depends a lot on the preference and on the surgeon. So there are a lot of people which do this procedure even with 1 or 2 millimeters of bone. In my opinion, this is not very predictable. It's very risky. So my number is rather 3 to 4 millimeters. So if there are 3 to 4 millimeters of bone in the apical coronal dimension, I'm going to inform the patient in advance that the chance of being able to perform the implant placement simultaneously to sinus floor elevation is very high. However, there is never 100%. So again, it's like 3 to 4 millimeter. If you have less than that, then I inform the patient that probably you're going to use a stage procedure.
What is the critical size of a buccal dehiscence to decide for a GPR procedure? Can a small dehiscence at a rough implant surface be left? And should the implant rather be placed deeper?
Very good question. So I would like to know the answer as well. So we don't have the answer to this question. So we don't have data from studies. So what happens with small dehiscences? So there is a minor amount of rough implant surface which is not covered. So possibly there is no influence on the implant survival and success. However, on the other side, there might be an increased risk of periimplantitis. So we don't know. Therefore, if this is the case, either we have to augment, so to cover this exposed implant surface, this dehiscence, by using, for example, GBR technique, or, as you mentioned in the beginning, we place the implant deeper. Again, in the front, in the aesthetic region, I think in that region, always we want to have the best aesthetics. We want to really to get more tissue, because anyway, the ridge dimension is reduced in the frontal region, so we would go for GBR. In the posterior region, if you have a dehiscence of let's say maximum 1.5 millimeters, of course you can place the implant deeper. You're going to end up with a longer crown.
What is your definition of a short implant? So meant diameter and length. And when you do it, do you adjust your surgical, healing, or prosthetic protocol against the regular implant?
So for me, less than 8 millimeter is short implant. So I consider an 8 millimeter long implant a regular implant. Below it is a short implant. With a, for example, 6 millimeter long implant, no, I don't modify my procedure, and I decide my procedure. So what is the loading time point? I decide is basically on the primary stability of the implant. So if the primary stability of the implant is not very high, so you're going to get the impression that, you know, it might be higher. In that case, I decide to wait slightly for a longer time period.
Mm-hmm. What's the relevance of the insertion torque? Is there any at all?
So insertion torque together with the implant stability quotient. So these two elements are basically the most important clinical parameters, or actually something which is measurable for us clinically, for the decision making whether we go for immediate restoration or not. If you take a look at the clinical literature, pretty much, I would say 80 or even more, probably even more, percent of the clinical studies on immediate restoration, which by the way are showing very, very good data in terms of implant survival and bone stability, they do the decision, they require at least 30 to 40 Newton centimeter of insertion torque, and the clinicians which are using the implant stability quotient, they require at least 60 to 65 ESQ in order to perform an immediate restoration.
Okay. If you place 2 implants or more, for example, 236 to 37, do you think that they need to be connected?
I think they don't need to be connected. However, it makes sense. I always connect these 2 implants just due to the fact that the technical and the clinical procedure is easier. So it's easier to find the exact position of the implant, to place the 2 connected crowns, to construct a perfect interdental contact between 2 implants. It's very demanding. So of course, if you connect the implants, you don't have to think about this. It's just for clinical and technical reasons.
Mm-hmm. What kind of bone density is required to place implants in the posterior maxilla?
I think the bone density cannot really be measured. I mean, you can measure bone density in the CT with Hansfield units, but this doesn't have any major clinical implication. The most important element is what is the primary stability of your implant. So I would say this is the important question. And the bone densities are different type of classification, like for example the one from Albertson and Zarb from 1 to 4. I don't really think that this has a major clinical implication.
Okay. So what are the indications to perform socket preservation?
So the indications to perform, I'm going to call it ridge preservation, so is basically 2. In the anterior region is the one that we want to keep the volume of the tissue. So in our clinical practice, in the front region, we generally, in the front region, we go for type 2 implant placement. So up to 2 months after extraction, we place the implant. So of course, in this case, the socket or basically the bone substitute is not also integrated yet, but our main goal is to keep the volume of the soft tissue. In the posterior region, if we have to wait for longer periods, so let's say more than 3 or 4 months, in this case, it's advantageous to place some bone substitute which might facilitate the procedure. Like, for example, if you have a reduced vertical amount of bone in the posterior maxilla, and if you place some bone substitute, we probably reduce the risk of a need of a sinus for elevation. However, we have to be honest, there is not a lot of clinical data on this. And on the other side, we have a narrow ridge, for example, in the posterior mandible. If we place the ridge or we use the ridge preservation, for sure, we reduce the need of GBR procedure at a time point of implant placement. So again, to wrap it up, in the posterior, if you want to simplify the bone augmentation, bone management technique, then you go for this. In the anterior region, to keep the volume really in the aesthetically demanding cases.
Mm-hmm. What do you think about immediate implant placement in anterior region? Do you ever do it?
Yes, of course, we do this. However, not very often. So if you can live, you can accept, you and your patient, let's say 1.5, maybe 2 millimeters of soft tissue recession, then you can go with this. So for example, a patient with a low lip line, the patient which doesn't care, the patient with a soft tissue excess, this is a very predictable option. However, we know today that even if we combine bone grafting and even if we combine soft tissue grafting, there is still quite an important percentage, I think around 20, maybe between 20 and 40% of cases in which we end up with 1.5 millimeter of recession. And there are no, not yet really predictable parameters, again, for the selections of these patients.
Okay. Do you recommend PRTF, the plasma-rich growth factors, for socket grafting procedures in place of membrane?
In our clinical practice, we don't use this, but however, they are, in particular in the past few years, so basically the second or even the third generation of this type of product, which really shows very promising, very interesting results. However, I think we need more clinical data. The first generation of this type of product did not really show a lot of benefit.
Okay. In comprehensive implant rehabilitation, what is your occlusion scheme of choice to establish? Fixed against overdenture? So
in the fixed, whether implant or tube supported, actually there are no differences. In the protrusion, you go with just basic anterior guidance. In the lateral protrusion, you go either with a canine or a group guidance. There is actually not major differences. I mean, of course, very often in the maxilla there are some aesthetic reasons to choose one or the other. For the removable, so for an implant supported overdenture, it's recommendable to left minor open bite in the front. So basically, like just some freedom in the front, and in the posterior region for the lateral protrusion, we generally go for group guidance in the lateral protrusion, so just unilateral. Okay.
So we are running out of time, Dr. Benic. We heard a lot of questions concerning the entire field of implant dentistry, about surgical techniques, about complications and strategy in planning. I would like to know, do you have recommendations how to minimize the risk for complications in surgery?
This is a very general question. I think this is something important for everybody. I mean, for every clinician, which is practicing any type of surgery. I think that's really, for sure, it's very important to really to perform the case selection and really to choose to treat the patient according to someone's skill. So not to try to overdo, particularly in the beginning. For sure, it's important. I mean, this is something for every complex treatment, whether surgical or not, to really to perform a serious and careful preparation of the case, and finally to really to have sufficient amount of time, really to reduce the amount of the human factor-based error.
And to finalize my last question, what advices do you generally give a starter in the field of implant dentistry?
I think this question goes very well in line with the question about reducing the risk of complications. So again, this is pretty much the same answer. Again, so really try to avoid, having stress when you do the procedure. Really prepare yourself. And I think something also very important, which is actually for every type of implant treatment, is whether simple or difficult, really to start the treatment with the end of the treatment in mind. And of course, we are speaking about the backward planning. Really, so it's very important really to find out, so what are the patient's desires, and so what is really the prosthetic treatment plan. So this can be just a single crown or maybe just or complex reconstruction type. But so after the definition of the final prosthetic treatment plan, only then really we can correctly plan the surgical treatment.
Okay. Dr. Benic, on behalf of all attendees, participants, I would like to thank you very, very much for this brilliant contribution and your time. If your questions have not yet been answered, the remaining questions will be answered in the forum of Dental Campus. As I told you, the access is free. We hope you appreciated our service, and on behalf of the whole Dental Campus team, we would like to wish you a nice evening and thank you very much for your participation.